Hi everyone, my name is Natasha Lukert and I'm a Program Development Officer at the Workers Health and Safety Center. Thank you so much for joining us this morning for this webinar. The webinar is looking at lessons from long-term care, and as some of you may know, residents and workers in the long-term care sector have been particularly hard hit by COVID-19, and there have been far too many deaths so far. So today we'll reflect on what's happened in the sector so that we can learn from these tragedies. And it doesn't seem like COVID-19 is going anywhere anytime soon. So it's really important that we look at the lessons that we can learn up until this point. It's going to be a 15-minute presentation, and then I'll take questions as well. So what we'll review is the directives for the long-term care sector. So those are the 5 directives that have been released by the Chief Medical Officer of Health. We'll review the testimony from legal challenges about what's allegedly happening in some of these care homes. And we'll look at the impact on residents and workers. And finally, we'll consider how that experience can be used to make all workplaces safer, especially as the government looks to reopen the province. Concerns about the long-term care sector are not new, unfortunately. Workers in the sector, represented by many unions, have been raising concerns and red flags for years, and now maybe we can all see why. What are directives? So directives are, they come from the Chief Medical Officer of Health. And that's Dr. David Williams, who's shown in the picture on the right there. And he has the power under Section 77.7 of the Health Protection and Promotion Act to issue directives to any healthcare provider or entity. And those healthcare employers are then required to immediately implement the precautions and the procedures in the directives. These directives are legally binding, meaning that employers must follow them. But if there's any conflict with the directives and the Occupational Health and Safety Act and its regulations, then the Occupational Health and Safety Act trumps the directives. As of today, 3 directives apply to the long-term care sector. Those are directives 1, 3, and 5. And directive number 1 was issued on March 30th. It's directed at all healthcare providers and healthcare entities, including long-term care. It requires point-of-care risk assessments to be performed by every healthcare worker before every patient interaction. It's active screening and identifies long-term care residents with symptoms of COVID. And based on those symptoms, the healthcare worker identifies residents suspected of COVID-19 infections. If a healthcare worker is working with someone suspected, presumed, or confirmed to have COVID-19, droplet precautions should be taken according to Directive 1. And if the worker is expected to be around an aerosol generating medical procedure, such as intubation, on a suspected, presumed, or confirmed COVID-19 case, airborne precautions are required. So that breakdown is in this table right here. It shows the type of activity or interaction that a healthcare worker could have and the type of PPE that's required. So the major difference is the use of N95 respirator masks, which look like this. So there's a few different types of these N95 masks. And we did a webinar on PPE protocols last week that you can look at. It goes into greater detail about what's required and when. But basically this provides a higher level of protection than the looser surgical masks, because these are fit tested to the individual. So that's the major difference between what's required for these different types of activities. So you'll hear throughout the presentation those 2 terms, the droplet or contact precautions, or the aerosol generating medical procedure. So I'll often refer back to this table throughout the presentation. On April 10th, Directive number 5 came out, and it was targeted at hospitals and long-term care homes, which set out new requirements, particularly around PPE. And Directive 5 requires healthcare workers to do a point of care risk assessment before every patient or resident interaction. And we heard that with the last directive, but for this directive, if a healthcare worker determines that based on their assessment, but also their professional and clinical judgment, that certain health and safety measures may be required, their employer must provide them with access to those appropriate controls. And the directive makes explicit mention that those controls include N95 masks, and that the employer will not unreasonably deny them access. Directive number 5 also requires that if a worker needs to work within 2 meters of a person suspected, presumed, or confirmed to have COVID-19, the worker must have access to N95 respirators or other appropriate PPE. And in general, long-term care homes, all workers must wear surgical masks at all times. So in this slide, that's the mask that's at the bottom, so the N95 is at the top, and that's the one that I have here. That's the version of the N95 I have here. And at the bottom, it's the surgical mask, which is not fit tested, just to make the distinction. And Directive 5 also talks about providing workers with PPE and making sure that they know how to use it. So making sure that they know how to take it on or off, and developing contingency plans if there is a case or might be a case of a shortage. And that should be in consultation with the union if there is one in the home. Employers also have to explore all avenues to obtain sufficient PPE. Directive number 3 is specific to long-term care homes. It was issued earlier, but was updated on April 15th, so that's why the numbers are a bit different. It's the longest directive to date, which is not surprising given the bulk of cases in the sector. And it's important for a number of reasons, but to start with, it defines an outbreak as any one confirmed lab case among residents or staff. And a key part of this directive is cohorting. That's separating residents based on whether or not they're sick or well, and separating staff whether or not they work with the well or with the sick. Cohorting of patients can be done in several ways, and the different ways are outlined in the directive based on the infrastructure in the individual home. So a few examples are options like moving residents to different accommodations to maintain the 2-meter distance, separating the infected from the uninfected, or using other rooms that are not normally used for accommodations, but that would provide that level of protection, that 2 meters or other precautions. And staff cohorting follows patients. And what I mean by that is that staff can be assigned to either work with ill residents or with well residents, but not both. And different precautions would then be required for each staff group depending on who they're working with. In smaller long-term care homes or where physical distancing of that 2 meters isn't possible, the directive is for all staff to use precautions as if all residents are potentially infected. The directive requires that residents are also actively screened, and if there are symptoms, to test, to isolate, and to initiate the series of steps that are in the outbreak protocol in the home. Those steps really shut down the workplace for movement in and out, except for the workers. Directive 3 requires that an infected patient must be isolated in a single room if possible, and staff must take contact and droplet precautions. So once again, referring back to that table, and workers who have been potentially exposed without appropriate PPE must self-isolate for 14 days. If a worker tests positive and is symptomatic, they cannot attend work, and like when there is a suspected resident case, the home must immediately implement the outbreak protocols. Work in long-term care is often part-time or piecemeal, so workers often work several jobs to make ends meet at several homes, and this creates the possibility of infection between the homes. So what the government did is they passed a regulation limiting staff to one employer, and that order was reinforced in Directive number 3. It references it, that order in this directive, and that was, I believe, under the Emergency Act. Don't quote me on that. So these directives came out on March 30th, April 10th, and April 15th, as I mentioned. So fairly close to one another. And shortly after that, 2 unions representing healthcare workers took legal action against long-term care homes in Ontario. One was the Service Employees International Union, SEIU. They filed an emergency application at the Ontario Labour Relations Board against 3 private long-term care homes. And the Ontario Nurses Association, I'll refer to them as ONA, they applied for an emergency injunction against 4 long-term care homes. And between those 3 homes at SEIU and 4 homes at ONA, there were 2 of the same homes at both of them. So there was crossover of 2 homes. So in total, there are 5 homes that were implicated in these these legal challenges. Only one was a court challenge, and that was the Ontario Nurses Association asking the Ontario Superior Court for an emergency injunction. And in general, an injunction is to prevent a party from doing certain acts. And in this case, on April 18th, ONA asked the Superior Court for an injunction alleging breaches of the directives and the Occupational Health and Safety Act. More specifically, ONA was asking the court to order employers to provide protections that were laid out in the Directives 3 and 5 that I just reviewed. Directive 5, as we talked about, allowed care staff to determine the appropriate PPE and have access to it based on their point of care risk assessment and their professional and clinical judgment. And Directive 3 required employers to follow the isolating and cohorting practices, some of which we just reviewed. On April 20th, SEIU, the Service Employees International Union, filed an emergency application with the Ontario Labour Relations Board, citing a failure to provide proper protective equipment, materials, and training for workers, and also they accused them of failing to take every precaution reasonable in the circumstances for the protection of a worker. And the wording echoes employer requirements or obligations under the Occupational Health and Safety Act. And that one will keep coming up, 25(2)H, taking every reasonable precaution, because it's a very important, it's in a very important catch-all clause that's often cited in orders. And more specifically, the SEIU cited unlawfully inadequate responses to the COVID pandemic, a lack of transparency about infections, critical shortages of PPE, and severe understaffing at the 3 homes that were named. And the union's press release cited the death of 68 residents and 1 personal support worker at 3 homes implicated in the application. This is some of the testimony that came out during the Ontario Nurses Association application. They talked about, it really underscored a lot of the concerns that many unions have been making for quite some time, and they were very troubling. They testified that N95s were being given out only when interacting with confirmed cases rather than with suspected or unconfirmed cases as required by the directive. That access to N95s was being denied despite a confirmed diagnosis and point of care assessment that we talked about with the clinical and professional judgment. And that an employer told staff that N95s were unnecessary, in another case that there were not enough, or that they will only be provided for swabbing a patient. Sworn court testimony included claims that management was controlling access to PPE with lock and key, or that there was a lengthy bureaucratic process to be able to access the PPE, and that they were being told to use surgical masks with confirmed cases. So those are the unfitted masks that I talked about earlier, or that they were performing aerosol generating procedures without adequate protective gear. So some very serious allegations. And the counts do not stop at PPE. Other claims related to cohorting or a lack thereof include no effort to cohort or group sick or ill workers, rooms of 4 residents with a combination of some infected and some not, no isolation of residents suspected or being infected with COVID, and residents who are symptomatic allowed to be anywhere in the building. So this is a collection of different testimonies from the different 4 homes. It's not to say that each was happening in every home, but either way, in each location, the court testimonies paint a very troubling picture. On April 23rd, the judge granted the injunction and gave 2 key orders. The judge required the employers to follow Directive 5 and provide nurses and staff with access to fitted N95s and other appropriate PPE when their point of care assessment tells them it's necessary. And the judge also required the employers to implement isolating and cohorting requirements for staff and residents that are in Directives 3 and 5. Going back to the SEIU challenge, on April 24th, the Labor Board gave its decision with the following orders for the inspector in each of the homes to conduct weekly on-site inspections and to produce that report to SEIU within 24 hours, for an inspector to attend every Joint Health and Safety Committee meeting, for the employer to implement administrative controls, so that could be something like grouping or cohorting, employers to provide weekly reports on staffing levels, and for visitors and staff to wear appropriate PPE. In general, there are 626 long-term care homes in Ontario with about 78,000 beds. And there were 5 long-term care homes subject to these legal challenges. And they had only 928 beds amongst them. We reviewed the directives and about PPE and cohorting, and we reviewed the testimonies by workers in the workplace. And the orders and injunction came on April 23rd and 24th. It was a Thursday and Friday. And by Monday, April 27th, in the 5 homes, those practices that were talked about, there were 92 deaths in those 5 homes that we just talked about. So combined, these locations averaged 10 deaths for every 100 beds. And at the same time, across the entire long-term care sector, there was less than 1 death per 100 beds. So what does that mean? What do those numbers mean? How do they translate on a larger scale? Around the time of the legal action, the homes subject to the orders and injunction had a 10 times higher incidence rate of deaths amongst residents. The data, it's important to note that the data was from the Ministry of Health and Long-Term Care up until April 27th. And it shows the numbers of workers infected in those homes, but it didn't show how many have died. However, we do know that 1 SEIU member died of COVID-19 after working in one of the long-term care homes that was implicated in their labor board challenge. And this week, an ONA nurse died who worked at a long-term care home in London, Ontario. And in fact, as I was developing this presentation over the last 2 weeks, I had to keep updating the amount of workers who had died of COVID-19 just within a 2-week span. So as of today, and it could change. Unfortunately, it does, or I hope it does not change. 4 personal support workers have died, 3 women and 1 man, all between 51 and 61, as well as an environmental service worker who was in his 50s. As I mentioned, a nurse also just died. And as a result, the SEIU is asking for a public inquiry and criminal negligence investigations into the deaths of both residents and workers. And the Toronto Star also came out with an article reporting that many experts and advocates have warned for years that chronic understaffing, precarious work conditions, and poor workplace safety at nursing homes puts Ontario workers and also seniors at risk. And that they're not at all surprised that COVID is exacerbating these apparent flaws. The practices we've reviewed are concerning, and the largest population of workers who have been hit are healthcare workers. It might not be surprising, but certainly this chart is very alarming. In early April, about 10% of Ontario COVID-19 cases were healthcare workers, and in early May, that amount was up to 16%. And as you can see, based on this graph, that increase has been an ongoing trend. And workplace outbreaks aren't just in long-term care homes, they're not just in healthcare. 10 Pearson Airport and limo taxi drivers have died of COVID-19. Personal support workers have died, as I said. 1 week, 4 taxi and limo drivers had died. The next week, 10 were reported. There have been multiple outbreaks in food processing plants, grocery stores, and warehouses. And it's unprecedented, and it's alarming, and hopefully we don't see any more of these headlines. The provincial government spoke to various employer groups, which created industry guidelines, and about 60 documents have been developed for various industries and occupations. It's unclear how guidances will be used for enforcement of COVID control measures, but the lesson from long-term care is that protective measures on paper don't protect workers or anyone else until they're put into practice. So inspectors have the power to use standards and guidances to assess compliance and to make orders under the General Duty Clause in the Occupational Health and Safety Act, which I mentioned before, and that employers must take every precaution reasonable to protect workers. The Ministry of Labour inspectors do this all the time with standards from CSA and others. So the only point of concern is that we want to make sure that the guidance is protective enough and doesn't promote a lower standard of reasonableness that could undermine good enforcement. So that's, yeah, we need to make sure that the guidances are providing a high standard for safety around COVID. Joint committees always play a central role, but especially right now during COVID, they can ensure guidance is being followed by the employer, and they can recommend improved precautions for workers around COVID. They can also inspect the workplace. They must inspect the workplace monthly and can investigate fatalities. The employer is required to report all positive tests to the Joint Committee as well as to the Ministry of Labour and to the union, and that has to happen within 4 days. Also, if it's a healthcare facility, then the employer has to let the public health unit in the area know of a confirmed case. As more people return to work, joint committees may play a critical role in ensuring safe work. And we've seen that when employers don't follow the right practices, the virus is not forgiving. Thank you for joining this webinar. We have a range of virtual training courses now. Usually it's in person, but we've adapted because of everything happening. And there's a new COVID-19 module. It's a half-day course. And we're doing that because no workplace or worker is immune from the hazards that we're all facing now, but we can try to make sure that we're more prepared to control these hazards. And I hope that this presentation has provided with you on some insight into the alarming rate of infection and of deaths in the long-term care sector and what we can do moving forward. So please take a second to respond to this poll, to give us feedback, and please feel free to keep talking to us, keep connecting with us. We're on Facebook, we're on Twitter, LinkedIn. This webinar can be shared afterwards, and we'll also have it up on YouTube. We want to prevent the spread of COVID-19 by increasing awareness around it. So we hope that this has helped in some way relay those lessons that we have to learn in the long-term care, from the long-term care sector. So now I'm going to address some questions. I'm just going to look at the time. I think we have about 10 minutes. Okay, let's address some questions here. Why is the long-term care sector being hit so hard? I can't say for sure, but I do know that advocates and workers have pointed to ongoing and historic issues, like I mentioned, with overstaffing, understaffing, and underfunding. And I've also heard theories that it's because it's a sector that's dealing with more vulnerable patients and older patients. But what I've heard most is criticism around the fact that we're inheriting a lot of problems that already existed. What is the definition of an outbreak? So an outbreak in one of the directives talked about what the definition was. And the definition of an outbreak is one case because of the transmission rate, the alarming transmission rate of the virus. Once one case has been confirmed by a lab, that's considered an outbreak. And of course, proper protocols must be taken after that. Okay. In the chart, are you saying 9.9% of the COVID deaths in long-term care were in those 5 care homes? No, not quite. Those care homes, those 5 care homes all have different numbers of beds. So what we did is we divided the number of deaths by the number of beds. So a care home with 100 beds and 10 deaths would have a 10% death rate. And the point here is that the homes that were subject to legal action, they had an average of it was 9.9 deaths per 100 beds, when the whole industry rate was 1 to 100. So these 5 homes were significantly worse compared to the whole industry, which is perhaps why they were implicated in those court challenges. Okay. I have another question about those legal challenges. It's why did the unions go through different legal avenues? I can't say for sure, but I can say that the unions appeared to be looking for different remedies. So the Ontario Nurses Association was looking for an injunction based on the directives and also the Occupational Health and Safety Act, whereas SEAU was looking for orders under the Occupational Health and Safety Act by the Ontario Labour Relations Board. So they were pointing to different practices and different directives and different laws But the principle was the same, that they felt that workers were not being protected. And in both cases, I would say that they would feel that the decisions were favorable for workers in both outcomes. So whether or not what avenues they chose, I would say that they were favorable decisions in both cases. I have a question here about private versus public homes, whether or not these homes were all private, that were part of the legal challenges. And the answer is yes, they were all private long-term care homes. I have seen some reports, one by the Toronto Star, that analyzes the difference between private and public homes and the rates of infection. And I believe, don't quote me, but I believe that for private homes, they're 4 times more likely to have infections than municipally owned homes. That just came out in the Toronto Star. But once again, take a look at that Toronto Star article. They're analyzing a lot of data around long-term care as well right now. So it's being looked into, this outbreak and this crisis in long-term care, which absolutely must happen. Okay. Where does it say that an employer has to tell us if there's a positive case in our workplace? So you would look at section 52.2 of the Act, and that says that when an employer is told of an occupational illness, they need to give written notice to their joint committee or health and safety rep and the union, if you have one. And they have to do that within 4 days. And also if it's a healthcare employer, then they have to notify the public health unit in the area. Okay. What's the difference between guidances and directives? Directives come from the Chief Medical Officer of Health, and I showed a picture of him in one of the first slides. And whatever the directives say, that's legally binding. But for the guidances, those often come from non-government sources, and they can't be directly enforced, but Ministry of Labor inspectors could use those guidances to enforce the general duty clause, the 25(2)(h), taking every reasonable precaution for the protection of the worker in the circumstances. So guidances are more of a recommendation, but they can be enforced, or when Ministry of Labor inspector is issuing orders. What else? Okay. I heard that certain homes are bringing in the Army. Is that true? I did see a news article talking about the Canadian Armed Forces going to provide support to some of the homes. I'm not sure what's happened with that, but I do know that some of the homes that were mentioned were the ones that were implicated in the legal challenges. And I'm not sure what's happened since then, but we'll see. I think we're out of time. Yeah, we're out of time. But if you have more questions, and I see there's more questions, please send us your email, and we'll contact you and let you know our take. And yeah, so send us your email, send us your question. Thank you so much for joining. We hope that this has been helpful to your workplace or your workers, and thanks for tuning in. Bye for now.